Hello everyone, this is Dr. Garima Sachdeva, and today we'll be discussing about the preventive strategies for preeclampsia and what is the role of aspirin and calcium in it. Hope you find it useful.
Next guideline, low dose aspirin and calcium supplementation. So, for the prediction of preeclampsia, what are the in the history, what all will you take? So, increased risk is seen if there is advancing age. So, that is a most significant predictor. BMI
Okay.
is the second most significant predictor.
Mm.
Nulliparity, Afro-Caribbean race, history
Mm.
of patient-induced conception,
Mm.
personal or family history of preeclampsia, particularly if it was associated with onset or delivery at every gestation, at
Okay.
early gestation.
Okay.
Okay.
This advancing maternal age only for primary or even in multipara.
For everybody, it is
Okay.
the
In any case, okay. Mm.
yeah. Then there are certain markers also for predicting, so which I've highlighted. They increase the risk of preeclampsia,
Mm.
SFH1, SEND, and beta HCG, high beta HCG levels.
Mm.
Others are the ones which decrease. Okay.
Beta HCG elevated.
Hmm.
These three are okay. All these
Indicated
three
these
elevated.
levels
Okay.
are elevated. If these
Okay.
levels are high, they
Mm.
indicate higher risk of preeclampsia. Other levels, if they are low, they
Okay.
indicate the
If there's
higher risk.
previous history, we can okay go for these tests.
According
Okay.
to the NICE guidelines, the latest one, we are only doing placental growth factor 20 to
Okay.
35.
Okay. Okay. Okay.
Other things, like if they can just ask you like which of these helps in predicting of preeclampsia, and
Okay.
whether the levels high levels predict or low levels predict.
Okay.
So for
Okay. Okay.
21 SEND and beta HCG, if the levels are high,
That
they
okay.
are
Hi.
search for preeclampsia. For placental growth factor, PAPA, VEGF, ADAM 12, the
Mm-mm.
levels are low, they are indicative of preeclampsia.
Okay.
Then other things which are effective: booking history, mean arterial pressure at presentation, placental biomarkers we have already studied, uterine artery Doppler where you see high PI, RI or notching. It is again a predictor. So the best one which has the highest prediction value is if you use everything. The you
Okay.
history without the history dependent factors, you check the blood pressure,
Mean
you
arterial pressure.
yes,
Mm.
you do the placental biomarkers, uterine artery Doppler. If you do everything, then it has for early onset preeclampsia, it has a sensitivity of detecting 88.5%, and late onset it has a sensitivity of predicting in 46.7%. Okay.
Do we really do this calculate this mean arterial pressure for every patient? We are
No.
just seeing their BP only, no.
Hmm.
Need not calculate and all, no, ma'am.
It is just this no
Practically, we don't do right.
practically we don't do,
Okay.
yes.
Only for theoretical purpose.
Then this table is very, very, very important. So
Mm.
aspirin, which patients do you give aspirin? Okay.
Mm.
So aspirin, if any of the high risk factor is there, any single or
Mm.
or more than two or more than one moderate risk factor is there. Okay. And what is the
It's
dose?
high risk as well
Only,
as moderate risk.
okay.
Mm.
So high risk, if any of these high risk is there, any parameter, then you give aspirin, or
Okay.
moderate two factors are there. So they
Okay.
can give a scenario and they can ask you.
Mm.
Remember this. And what is a dose? You give 75 to 150 mg, start from 12 weeks and continue till delivery.
Okay.
Okay.
Okay. The 75 to 150 depends on the
So the old guidelines said
BMI of the
75, the
patient.
recent guidelines say 150.
No, no. Like, how do we give to whom 75 and to 150? Is it dependent on the BMI of the patient, their
No,
weight?
it is
Is
not. The older guidelines, they have written 75. So whatever,
okay.
like in the question, whatever you get,
Okay.
you answer accordingly. The newer guidelines, the latest one says 150.
Okay.
Then what are the high risk factor? If there was a history of preeclampsia, especially when
Mm.
occurring need with adverse outcome.
Mm.
If there was a history, there is a history of multifetal. If it's even if twin triplet, you have to give
Okay.
aspirin. This is
Mm.
again important thing. If there is chronic hypertension, that we have already read.
Mm.
Type 1 and type 2 diabetes,
Mm.
renal disease, autoimmune diseases like SLE or APLA. Okay.
Okay.
So
Mm.
if disease is there, you have to give aspirin.
Okay.
Moderate factors are nulliparity, obesity, that is BMI more than 30, family history of preeclampsia,
Mm.
socioeconomic characteristics like African American race or low socioeconomic status,
Mm.
age 35 or older, or
Mm.
personal history factors like low birth weight or small gestation age or previous adverse pregnancy outcome more
Mm.
than 1 year into pregnancy interval.
Okay.
So you just have
So this is more than one. More than one means there should be a minimum of two criteria.
yeah, at
Whereas
least
the high risk even if there is one risk
yes,
factor. Mm.
yes. So
Okay.
this was about the recommendation. About calcium, the latest NICE guidelines say that it is not recommended. But in
Okay.
the TOG article, which was 2014, they have written that it helps in prevention. So
Okay.
the dosage that they had written it was 1.5 to 2 gram elemental calcium per day.
Mm.
Frequency daily with the total daily dosage divided into 3 doses. When do you
Mm.
start? You start from 20 weeks until the end of the pregnancy, and the target group is all pregnant women, particularly who are at high risk of gestational hypertension and settings and in the areas of low calcium intake. So this
Okay.
was
Mm.
old talk 2014, but the NICE 2021 guidelines say do not offer calcium, magnesium, or potassium supplements as a
Mm.
method of reducing blood pressure.
But anyhow, like any pregnant female is on calcium.
Usually we give it.
So this was all about this talk article on the predictors of preeclampsia and role of aspirin. Hope it was useful. Thank you so much for watching.